Good morning, everyone, and welcome to today's webinar hosted by PYA, Top Insights from the 2023 Hospital OPPS Proposed Rule, including Rural Emergency Hospitals. PYA is happy to present today's webinar on this important topic. You will have the opportunity to submit questions to today's presenters by typing a message into the question pane of the control panel. We'll collect these and address them by email after the webinar. All of our webinars are recorded and released with a copy of the slides after the event. With that, I would like to introduce Martie Ross, Consulting Principal, and Kathy Reep, Consulting Senior Manager at PYA.
Good morning. This is Kathy Reep, and I'm going to kick off today kind of talking about some of the key issues that were included in the outpatient rule. I'm going to walk through the first 8 items on our list, and then Martie's going to step in with some issues related to rural emergency hospitals and an RFI that was included within this proposed rule. This is a proposed rule that was issued by the Centers for Medicare and Medicaid Services related to the Medicare outpatient prospective payment system that would be effective January 1, 2023. Comments on this rule are due on September 13th, and there are a number of issues that I would encourage you to be thinking about commenting on. Martie and I will both raise those concerns as we go through the presentation. But you can see that we have, again, a top 10 list of various topics that we identified in this proposed rule that we thought were important and wanted to call your attention to. So let's get started with the money. So the first issue that we're going to talk about, and then I'm going to have to go on to 340B and then come back to this issue because of how 340B is going to impact the payment rate update. But the first issue that we're going to deal with is what is the increase in the reimbursement, or is there an increase in reimbursement under this proposed outpatient rule? And so yes, there is a 2.7% rate increase that is included in this rule. This is essentially calculated using a 3.1% market basket increase minus 0.4% productivity adjustment. So that's how we come up with the 2.7. Claims data that was used to support this update was 2021 outpatient data. As you comment, think about calendar year 2021 and COVID and all of the huge volume of outpatient services that did not happen in the hospital unless they were emergency services because of the postponement of so many elective surgeries and the like. They are using the claims data from calendar year 2021 and applying to that cost report data from June of the June 2020 HCRIS release cost report data. Think about the fact that we have just recently gotten the inpatient final rule. And in that inpatient final rule, they had proposed an increase of 2.6%, but the final rule reflected an increase in the rates of 4.3%. So significant jump from what was proposed in inpatient to what we got, or what we will get. And therefore, it makes you wonder what is going to happen with this outpatient rule, even though they proposed a rate that was slightly higher, 2.7 versus the 2.6. Will we find ourselves come January, or actually come the final rule issued in November, will we see a jump in the outpatient rate similar to what was included in the final inpatient rule? It is something to be thinking about. And all of those arguments that you made in comments on the inpatient rule to support a higher rate increase, the increased costs of care, you probably need to make those again in this outpatient rule again, because this has been out there for a while. If you're going to get a 4.3% increase in inpatient, I would think that outpatient should be a little bit higher than is currently proposed. Those hospitals that fail to meet the quality reporting requirements would have a 2% reduction to their outpatient conversion factor. So recognize that the rates that we're going to talk about are the rates for those that are submitting the quality reporting data as required. The last couple of bullets on this slide gives you the proposed outpatient conversion factor and the proposed ambulatory surgical center conversion factor. $86.79 for outpatient services provided in the hospital setting. Currently, the conversion rate is $84.18. And then for the ambulatory surgical centers, we would be going from $49.91 to $51.32. Again, these are proposed and always subject to change. Remember that $84.18 that I have on this slide, which is the current OPPS conversion factor, because as we talk about 340B, we're going to talk about what CMS feels that number would have been if they had implemented changes to 340B in 2022. So let's take a look at what they're doing with 340B. The proposed rule itself essentially comes out with average sales price minus 22.5% for 340B drugs that are separately payable. However, the rule also says that we recognize that the Supreme Court, in its decision of American Hospital Association v. Becerra, found against CMS, and that their payment for the last few years, since I believe 2018, that payment rate of average sales price minus 22.5%, as opposed to other non-340B drugs that are separately payable, being paid at average sales price plus 6%, the Supreme Court said CMS erred and that they did not do a survey of acquisition costs prior to implementing this reduction in rates. So that court decision affected 2018 and 2019, but we've had that reduction through 2022. So any fix is going to ultimately have to move forward from 2018 through 2022. The Supreme Court essentially said, now y'all need to go back and figure out how you're going to address a payment rate going forward. As I said, the rule was sitting at the Office of Management and Budget when the Supreme Court issued their decision. There was some reference in the rule to the decision by the Supreme Court. And although they proposed average sale price minus 22.5, they came back and said, we believe that the final rule will say average sales price plus 6% for these separately packaged drugs that were acquired through the 340B program. They believe that that's what they will do. But there are some things to think about with this. First of all, there was a survey of acquisition costs that was done in 2020. Will CMS come back in a final rule and say, we're going to use that survey? Or will they hold that off until perhaps next year, or will they resurvey? So recognize that there really is a survey out there that was conducted in 2020. So they could fall back on that. The other issue is that when the average sales price minus 22.5 was introduced, this was done in a budget neutral manner, so that the payment rates, that base rate, the conversion factor, was increased by about 1.4%. At the time that the rates went down for the 340B separately payable drugs, the base rate went up. That base rate increase impacted all hospitals, not just those who lost money under this average sales price minus 22.5. But those hospitals that were not even eligible for the 340B program, such as your for-profit hospitals, they got this bump in the base rate. So what will be the effect of paying average sales price plus 6, even if that's temporary? What will be the impact of that change on the base rate? Well, on the previous slide that I showed you, the current rate is $84.18. CMS has said in the proposed rule that if they had been paying, if we took out budget neutrality, we paid average sales price plus 6 for these 340B drugs, this $84.18 in 2022 would be $83.28, so a 90-cent difference. So does that mean as we move forward, remember I said maybe we will get a bump in that 2.7% increase because of what they did with inpatient, but are we ultimately going to also see that $86.79 drop by close to $1 because of eliminating the budget neutrality? That money that had been spent on 340B drugs is now going to be spent on 340B drugs, and therefore they're going to have to move this out of the base rate. So concerning that, we've got an increase of 2.7 proposed, but fixing this from a budget neutral perspective on 340B drugs will probably cause a drop in that new rate that is proposed by close to $1. So as you're doing impacts and you're working on what is this going to do to my reimbursement for 2023, remember that budget neutrality is going to have to go away because that's going back into paying for those 340B drugs. I urge you to comment on this and to comment on how should CMS fix this issue going back to 2018 through 2022. We really want it to be fixed using new money. We don't want those providers who got a bump in their rates to have to give it back. Remember, that is every provider. It's not just those who didn't qualify for 340B. Everyone got a bump in their rates. So we do want CMS to do this using new money, if at all possible. The other issue is recognize that if they don't do this with new money and they adjust claims, this will impact patient liability. And so this becomes a concern in terms of what patients pay as well. So again, I would urge you to comment that any adjustments be done using new money, make it budget neutral, don't go recouping from providers. Yes, pay providers, but don't recoup from providers. Okay, let's go on to the next slide. There we go. The inpatient-only list. 2 years ago, we thought the inpatient-only list was going to go away. Now it looks like the inpatient-only list is definitely here to stay. They had proposed moving a large number of items off of the inpatient-only list 2 years ago, and they did start moving a number of orthopedic services, and then they turned around last year and brought them back. And therefore, we always monitor what are they going to come out and do with inpatient-only this year. And for those of you who aren't familiar with the inpatient-only list, this is a series of services, procedures that CMS determines are medically complex and invasive and should not be provided on an outpatient basis. So that means they are only going to be paid, only going to be covered if they are done in an inpatient setting. What they are moving forward with right now is they are proposing to remove 10 services off of the inpatient only list, and these would be maxillofacial procedures that they would be moving off of the inpatient only, but they're adding 8 services to the inpatient only list. And I've listed those for you on the slide: the total disc arthroplasty, implant of absorbable mesh for delayed closure due to soft tissue infection or trauma, and then several hernia procedures that, again, these would be moved to the inpatient only list. When something moves off of the inpatient only list and can be done in an outpatient setting, it is usually initially only allowed to be done in the outpatient hospital setting. Once it's been in the outpatient hospital setting for a year or so, then they start looking at, can we move this out of the hospital setting and move it on to the covered procedures list for ambulatory surgical centers. And this year they are proposing to move lymph node biopsies onto the covered procedure lists for ambulatory surgical centers so that ASCs could provide these services and be paid under the Medicare program. Prior authorization. This really raised its head just a couple of years ago in terms of certain Medicare services that were going to be inpatient, that were going to require prior auth in order to be covered under the Medicare program. So this year they are proposing to add facet joint interventions to the prior authorization list. However, this wouldn't be as of January 1, 2023. It would be the requirement for a prior auth, if this is finalized, would be effective for services on or after March 1, 2023. This is predominantly because we get a final rule sometime early November, we hope early November, and it's effective January 1. That really doesn't give providers a lot of time for services that are scheduled to go through the authorization process. So they are postponing, they would postpone any new services added for prior authorization until March. I've also provided on the slide a list of those services that currently require prior authorization. You can see that what they are adding kind of falls in line with these additional services. Questions in terms of, are these services that are appropriate to be covered under Medicare? Are they appropriate in this setting, et cetera? Things like vein ablation, rhinoplasties, blepharoplasties. Really the question of whether or not these should be paid for under the Medicare program, and what is requiring these services to be provided in a hospital outpatient setting. So this would be a change that would be, if finalized, effective in March. We've all dealt with this issue of off-campus clinic visits, and clinic visits that are provided in a provider-based department, but a off-campus provider-based department. And currently for providers, for those clinic visits, off-campus departments that were operational as of November 2015, those services are paid at a 40% of the outpatient rate. The 40% of the outpatient rate is considered to be equivalent to what would have been paid under the physician fee schedule. So we currently, all hospitals who have off-campus departments that have clinic visits, you get paid at 40% of OPPS. Well, CMS has recognized that this rule is currently also applicable to rural Seoul community hospitals. And they feel that these rural Seoul community hospitals should be exempt from this reduction in the payment rate and should be paid at the full OPPS rate for these clinic visits. This is what they are proposing to do. If you operate a sole community hospital, a rural sole community hospital, I urge you to comment on this to encourage CMS to move forward. But at the same time, CMS is saying, should we make an exemption, put an exemption in place for any other providers? They said, what about other rural hospitals, such as those under 100 beds? Should we exempt them from this 40% reduction for off-campus clinic visit services? If you are a provider that provides these off-campus services, you're rural, you're under 100 beds, I think, again, this is a good opportunity to comment and something that would be important to address because it would definitely be a boost to your reimbursement. Okay, next item that we're going to talk about is we always get into this drug issue in terms of single-use, single-dose packaged drugs. There was a proposal in the physician rule that came out, and we've had webinars on for the last 3 weeks, but this was something that was addressed in the physician rule, and now they are raising it again in the hospital outpatient rule to address the application to both hospitals and ambulatory surgical centers. And essentially what they are would be requiring is for hospitals to report when you use a single dose, single use packaged drug and you don't use it all, a portion is discarded, that you would report the JW modifier to identify the amount of that drug that was discarded, that was not used, so that you would not be paid for that particular drug. And then they're also saying to use the JZ modifier when you use that single dose, single use package, but nothing was discarded. So that whenever you use a single dose, single use packaged drug, you would wind up with a modifier on the claim. I think this is something that is also worth commenting on, and I'm going to do this strictly from the issue of administrative burden. Gut feel is providers should be trusted that if they don't put the JW modifier on the claim, it means nothing was wasted. So it might be worth commenting, using the JW modifier is one thing, but requiring us to always put a modifier telling you there was wastage or there was not wastage is perhaps taking it too far. So look at your processes and whether or not this would add to the administrative burden. So something that I think you should, I think it's worth commenting on. Next item to touch base on is organ acquisition costs. Last year, there was a major proposed rule related to organ acquisition costs, and this year it just reinforces that CMS is really focusing on organ acquisition, the costs that they are paying for this, and trying to come up with some ways to reduce spend. What they had proposed last year is that only those organs that were transplanted into a Medicare patient would be included in your organ acquisition costs. That became a major nightmare and was not finalized because in many instances you might be harvesting the organ and sending it somewhere else to be transplanted. You don't know that that particular patient was Medicare or not. So CMS did not finalize what they proposed last year, but now they're coming in and saying that they are proposing to exclude research organs from the calculation of Medicare's share of organ acquisition costs. this is an attempt or a proposal essentially to assure that Medicare doesn't share in the cost of research. So that you would be having to track the organ acquisition costs associated with any organs that were used for research, as opposed to a direct transplant into a patient. Those would have to be excluded from your calculation of costs. And in the proposed rule, it does kind of go through the process for how you would exclude those organs. And then finally, in terms of what organ acquisition costs they would cover, they are proposing to cover those costs that are associated with care of a patient who is a donor, but the donor dies from something such as cardiac death associated with the actual acquisition. So again, something worth commenting on, because that that would be a positive in terms of increasing what you would be able to report for organ acquisition costs. This isn't the actual harvesting. This is the hospital care that is provided to the patient when something unforeseen comes about as a result of the organ acquisition. Finally, the other item that I wanted to touch base on, and if you've read the inpatient rule, then you know this was both proposed on the inpatient side and then also was finalized with the final rule. So when they came out with the outpatient rule, they're essentially telling you this is what we've decided to do. But what they are moving forward with is a separate payment for those providers that use domestically produced NIOSH approved N95 respirators. So this is a additional payment that you're going to receive if you are using these domestically produced respirators. What they're going to be doing is essentially sending you every 2 weeks an interim lump sum payment for the use of these masks, domestically produced. And then there will be settlement at cost report in terms of how much they paid you versus how many domestically produced N95s you actually used. The rule goes through a great deal of information related to cost report changes and how you will report your use of these respirators, beginning with cost reporting periods on or after January 1, 2023. So if you are a January 1 hospital, then beginning this January, this is something you would need to be tracking and you would be reporting if you're on the calendar year. If you're on the federal fiscal year for your cost report or any other date, then again, this is delayed until actually the start of your fiscal year. But if you are a January hospital, you do need to start looking at this soon to make sure that it meets that you can do what the rule is asking you to do. So with that, I'm going to turn it over to Martie to talk about rural emergency hospitals.
Thank you, Kathy. 4 provisions in the proposed OPPS rule regarding the implementation of the Rural Emergency Hospital Program. As you will recall, Congress created this program in the Consolidated Appropriations Act of 2021, directed CMS to stand up the program and begin reimbursement for these REHs by January 1, 2023. An REH is a rural hospital that does not provide inpatient services, with the exception of skilled nursing services furnished in a distinct part unit. The concept behind an REH is that you can lower the fixed overhead costs for the hospital, thus protecting its financial position and reducing the likelihood of more hospital closures. Right about 4th of July holiday, CMS provided us with a proposed rule detailing the conditions of participation for rural emergency hospitals, and promised that in the OPPS proposed rule, it would furnish detail on the payments for these hospitals. So in the OPPS proposed rule, in addition to those payment policies, CMS has also addressed the REH quality reporting program, the process for enrollments of REH facilities, and the creation of a new start law exception specific to REHs. So let's get started with the quality reporting program. Back in September of 2021, CMS had solicited comment from stakeholders regarding the REH program in general, but specifically focused on appropriate quality measures for REHs. Congress, in the Consolidated Appropriations Act, provided significant detail on its expectations of quality reporting by REHs to ensure rural relevancy, to address the issue of a small number of patients that are involved in these measures, and in fact, meaningful measures that do reflect the quality of care being furnished at the facility. In response to that RFI, CMS received from the National Advisory Committee on Rural Health a list of 6 measures that the committee believed would be appropriate. CMS also noted that the Medicare Beneficiary Quality Improvement Program, the quality reporting program for critical access hospitals, CMS identified one of those measures, the one specific to emergency department communication in the event of a transfer, as potentially relevant. CMS also identified 2 claims-based measures they believe may be appropriate for REHs: use of contrast material for an abdomen CT, and then a hospital visit rate after outpatient colonoscopy. CMS certainly wants to utilize appropriate claims-based measures if they are relevant, because that certainly reduces the burden on the REH with regard to quality reporting. You take a look at those measures recommended by the National Advisory Committee. Almost all of those need to be extracted from the electronic health record, certainly creating a greater burden for these REHs. Appreciate, most REHs are likely to be critical access hospitals that make the conversion. At this point, CAUs participate voluntarily in quality reporting, based in large part on their capacity to complete necessary chart extractions. And so in creating the REH model, our intention was to reduce the burden on these hospitals. So be very careful in how we select those appropriate measures. CMS, in addition to these specific measures that are identified for consideration, they also identified 5 areas where they would like to see measures for REHs, such as telehealth, maternal health, behavioral health, emergency department services, and health equity. Here, they don't offer a specific measure for consideration. They simply say, we think these are important areas to the types of services REHs will be furnishing, and thus we want some vehicle to evaluate the performance of that REH on these specific areas. Finally, CMS went into a great deal of detail on the methodological, that's a hard one, methodological challenges associated with quality performance measure in low volume settings. So this is sort of the false flag issue that in a normal case, you may have 1,000 patients to which a particular measure applies, and thus the outliers tend to normalize in the data set. But if you only have 10 patients potentially subject to a measure, the outliers can have a very significant effect on results and provide a false flag regarding the level of quality provided in this facility. Bottom line here is CMS isn't committed to any of these measures at this point, and they are seeking further feedback from stakeholders regarding what would be appropriate, what are the critical measures with which to start, um, the growth in the number of measures on which REHs will be evaluated over time. So do we start with 2 measures, go to 4 measures, and 6 measures? CMS really is taking no position at this point. It's simply saying, here's what we received in terms of comments. Here's what we think is relevant. Stakeholders, give us the direction of where you want to see this program go. So obviously a very ripe area for comment if you are considering the REH program or a part of a system that may have an REH included. Providing this information and feedback to CMS on these points is absolutely critical. Well, let's talk about money. This was the eagerly anticipated regulatory provisions on how REHs will be paid. Remember, we're eliminating inpatient beds from these facilities, and we are moving away from cost-based reimbursement for those facilities that were critical access hospitals. And so CMS is challenged here in the proposed rule to develop the detail regarding the manner in which these facilities were paid, working within the confines of the statutory language. So the Consolidated Appropriations Act says that REH services will be reimbursed at 105% of the applicable OPPS rate. In the implementing regulations, CMS clarifies that copayment amounts owed by beneficiaries will be based on the standard rate, i.e. 100% of the OPPS rate, not the higher rate. And for many rural patients, this is great news. Critical access hospitals have tended, because of cost-based reimbursement, to have higher beneficiary obligations. Moving to this standardized OPPS rate should reduce some of that burden on rural residents. Next up, CMS clarifies that the 105% of OPPS rate will extend to services furnished in the REH's off-campus provider-based departments. The proposed rule includes a delicious explanation of reimbursement for off-campus provider-based departments, but the bottom line here is CMS made the decision not to apply that policy to REHs, and instead, given the historical position of critical access hospitals, to provide that those services furnished in those departments will be reimbursed in the same manner as on-campus departments. Next, CMS stated that the process for paying REH claims will be the OPPS claims processing system, but with the addition of an REH-specific flag. That means you as an REH will submit claims in the same manner as would a PPS hospital for OPPS claims. It's just your CCN number will signal to the MAC that you're an REH, meaning you'll be paid at that higher 105% rate. Again, CMS is very clear throughout the proposed rule that REH services are not hospital services, and thus payment for REH claims will not be considered for purposes of OPPS rate setting on a going forward basis. They are in fact a standalone, simply borrowing the claims processing for purposes of payment to these facilities. Most troubling, I believe, in this section of the proposed rule is how CMS chose to define REH services. Remember, we have a statutory provision that says REH services reimbursed at 105% of OPPS. So CMS then says, well, we have to figure out what REH services are. And CMS interprets the statutory language narrowly, I believe, to say that only those services that are in fact reimbursed on OPPS qualify as REH services. So it's not the fact that it's a service delivered by an REH, even if it has been sanctioned to deliver those services by CMS. It is only those services that appear on the OPPS list and are covered by OPPS that will qualify as REH services. Now, CMS goes even further and says, we're soliciting comment on whether we should actually use a narrower definition of REH services, and thus further contract the reimbursement these facilities would receive, because if they're not REH services, they're not going to be paid at the 105% of OPPS rate. So this, of course, then leads to a discussion in the proposed rule of what will payment be to an REH for non-REH services. And here CMS begins chasing its tail a bit, because it admits that what an REH is required to provide by statute, i.e. emergency department services and observation services, necessitate that an REH furnish services that are not reimbursed on OPPS, specifically clinical diagnostic laboratory services, outpatient therapy services. So CMS makes the decision that it will pay REHs for these non-REH services because they have to provide them to be an REH. You see the logic here? But they'll only pay them at the appropriate fee schedule rate, i.e. no 5% increase. So these services that an REH has to deliver to qualify as a rural emergency hospital, which are not reimbursed on OPPS, and thus under CMS's interpretation of the statute are not REH services, will therefore be reimbursed at the Medicare physician fee schedule rate or the clinical lab rate without that additional boost that one receives for the other REH services. Bottom line here is that, again, it's creating financial stress on these organizations. Congress intended that there be additional reimbursement to cover the higher fixed costs that these rural facilities with low volume have. But the final decision here for CMS is we're only going to pay for OPPS services covered by OPPS at the higher 5%. Anything else that an REH provides will be reimbursed at the standard fee schedule rate with no upward adjustment. The other half of the equation for a rural emergency hospital, in addition to that enhanced OPPS payment, is the facility payment. And this is a monthly payment intended to cover the higher fixed overhead costs for these rural facilities. In the Consolidated Appropriations Act, Congress gave us a very specific formula to follow to calculate the amount of that facility payment. And it goes something like this. So don't look at the slide yet, just follow along. CMS, please calculate the amount you paid critical access hospitals in 2019. Then subtract from that the amount you would have paid critical access hospitals had they been paid on a PPS basis. So for inpatient, outpatient, inpatient rehab, inpatient psych, and skilled nursing facilities, all of those services that costs provide, calculate what it would have been under a PPS system as opposed to the cost-based reimbursement that they received in 2019. Once you have that difference, then divide it by the number of critical access hospitals in 2019. And that will give you the annual payment that all REHs receive. The facility payment doesn't vary by size. It is just an X amount that each REH receives just by virtue of the fact of being an REH. So what we have in the proposed rule is a description of the methodology CMS used to calculate the facility payment. What we do not have is the actual calculation. And in fact, there are very few numbers that are included in the proposed rule. And as you'll see, the numbers they do provide conflict. Let's start at the beginning. CMS says we've got to calculate the total estimated cost spending in 2019. And they come up with this number just a little more than $12 billion. CMS decided that for purposes of calculating the facility payment, it would base the estimated spending on what's paid by Medicare as well as co-payments. And it actually has a pretty lengthy description of why it chose to include the amount in co-payment that was paid to these critical access hospitals, and believe that that would be more appropriate. Then CMS says, we're going to use claims data to figure out what critical access hospitals were paid. And in fact, we think it's more reliable to use claims data because when we went to look at cost reports for these facilities, we found that the number, the spend, was $450 million lower in the cost reports. And for some reason, CMS said, there were 42 fewer critical access hospitals that reported on cost report than had claims. Now, the issue here to figure out, and CMS doesn't provide a lot of clarification here, is when CMS is using the claims data, are they only using the interim rate? Because remember, if you're a critical access hospital, you're paid on costs. And during the year, when you're generating those costs and providing those services, during that year, you're paid at an interim rate. And how that interim rate is calculated varies by the type of services you receive. But after the year is over, you close the books. The critical access hospital generates a cost report, submits that cost report to the MAC. The MAC audits the cost report. And then CMS determines, based on the information in the cost report and looking at the historical claims paid to the critical access hospital, it determines what the final settlement would be, i.e. the difference between the reported Medicare costs and the amount that the facility previously received in payments. That's the final settlement. And in most cases, in fact, a very high percentage of cases, that's a positive adjustment, meaning that the critical access hospital will receive more money than it would have received under the interim payments. So it's a boost. If, however, CMS is only using claims data to calculate the amount the cause would have been paid in 2019, are they taking into consideration the final settlements that these cause received in 2019? If not, I believe that means they're undercounting the amount the cause were paid. And that's problematic because we don't have the actual calculations in the proposed rule to check CMS's math. So let's switch gears from finding how CMS calculated the estimated cost spending in 2019 to how CMS calculated the estimated PPS payments that critical access hospitals would have received if they had been under this different payment model. And at the end of the day, the number CMS comes up with here is just a little bit over $7.5 billion. And again, you're going to get the detail in the proposed rule of how CMS modeled what the CAW would have been paid under PPS, both for inpatient, inpatient rehab, inpatient psych, outpatient, as well as skilled nursing. And skilled nursing gets the added complication because in 2019 is when we converted the methodology for how we pay SNFs. And that became effective October 1 of 2019. So CMS has to make provision for using the old formula for January 1 through September 30, and the new formula for claims from October 1 to December 31. So all of that, again, is detailed out by method in the proposed rule, but we don't actually see numbers. Good news here is that CMS rejected a recommendation from MedPAC. MedPAC said because critical access hospitals reimbursement is not tied to the complexity of the patient, then we believe critical access hospitals miss certain diagnoses. And thus, we believe there should be an adjustment made so that, in fact, had they been PPS hospitals and had they been coding appropriately and catching these primary diagnoses, the reimbursement would have been higher yet. So rather than being, without complications or comorbidities for a particular DRG, in fact, had they appropriately coded, says MedPAC, these costs under PPS would have been reimbursed at a comorbidity level, a higher level. And thus, MedPAC wanted to increase the amount of what the PPS payments would have been, i.e. then reducing the amount of the facility payment. But CMS, thank goodness, decided it did not want to go down that route because there's no reliable data to make that estimate. CMS then provides extraordinary detail, insomnia resolving detail on how to calculate supplemental payments that would have been made to critical access hospitals had they been paid on PPS for new technology, outliers, clotting factors, indirect medical education, disproportionate share payments, uncompensated care payments, and low volume hospitals. It does all of those adjustments to the numbers. Again, we don't see the actual numbers, we just see the formula. But CMS did not include any adjustments for the PPS value-based purchasing adjustment. So they didn't attempt to predict whether a CAW hospital reimbursed under PPS would have had a readmission reduction program negative adjustment to their payments. They decided not to go that way. So at the end of the day, you get to the actual calculation, which is the difference between what they were paid and what they would have been paid, which comes in at $4.4 million, $4.4 billion, excuse me. You divide that by 1,368, which are the number of CAWs that were enrolled in Medicare at some point in 2019. And that gets you to the facility payment of $3.2 million. And then CMS says in subsequent years, we will not redo the calculation. We'll simply give you an upward adjustment based on the market basket percentage increase for that year. So where are the potential issues here? As we said previously, are there incidents where CMS undercounted the amount paid to critical access hospitals in 2019, the actual payments on cost-based reimbursement? There's this issue of interim rates, but also I didn't see anywhere in the calculation where CMS accounted for payments made for professional services to critical access hospitals operating under Method 2. So those dollars did not appear to be included. There's also some really interesting inconsistency in the numbers that CMS did provide. So these references, these page number references are to the Federal Register. So at page 44786, CMS is providing the final calculation of that facility payment. So it's saying, and this is the number, quote, of total projected amount of Medicare spending for costs if paid prospectively in 2019, and it gets to the number 7.68 billion. That's the number listed there. However, in an earlier discussion in the proposed rule, specifically the discussion of whether to include copayment amounts or not, CMS lists a number for total estimated prospective payments for costs in 2019 with copayments included, and surprise, that number is about $500 million lower. I've read through this several times. I can't reconcile the two. I think those descriptions are describing the same thing. I don't understand why one number is 7.68 and one number is 7.0. And if you do the math and use the latter number, the 7.0 number, as the amounts that costs would have been paid under PPS, the amount of that facility payment would have gone up by almost $500,000. So this isn't a small, accounting error. This is a significant amount in determining whether you are going to be willing to pursue REH status. So that payment, remember that payment, let's go back here a bit, ends up being about 3.2. It would be about 3.7 million if you used the alternative number that CMS listed. Also, worthy of consideration here with regard to the facility payment is the manner in which CMS made the conversion from swing bed reimbursement to skilled nursing facility reimbursement. CMS utilized the number of swing day beds, but we know from the data that across the board, swing bed days are always lower than the skilled nursing days, even when you control for severity of condition. And so again, that's another opportunity for undercounting because they were considering too few days. So it's not uncommon for the same condition to have a patient in a swing bed for 6 days and to be in a skilled nursing facility for 29 days. But we're only going to use the 6 days using the SNF rate to calculate what the CAW would have been reimbursed. Finally, and I know it's minor, but it still just annoys me, there are 6 critical access hospitals that closed in 2019. CMS decided to include those 6 hospitals in the total count of critical access hospitals, and it made no adjustment for the partial year that that facility was in place. So at that facility, there's one here in Kansas that closed in March, I believe, March of 2019. We're treating that as if it was there the whole year generating claims, and it wasn't. It stopped submitting those claims after Q2. But CMS made no adjustments there. Again, it doesn't make a significant change, but at least it's consistent in how we provide those numbers. Enough about payment. Let's talk about the REH process. What we do know is that we will submit a change of information application as opposed to a new provider application. The billing privileges will be effective as of the date of the successful survey completion. And oh, good news, REHs will not be required to provide move notices to their patients. What we don't know at this point is the transition process. And for those of us that are old enough to remember the days of critical access hospital conversions, there were sometimes some pretty messy periods of time of cash flow challenges as a hospital went from PPS over to critical access hospital. Question is, how are we going to manage that with this transition? Is it appropriate for the facility to continue to receive critical access hospital payments until its REH privileges become available? Or does it have to, in fact, stop providing inpatient services for a period of time and thus not be eligible for any reimbursement under the existing critical access hospital? So I think another important area for comment to CMS. Finally, the Stark Law exception. Again, remember, as I said, CMS says again and again, they are not hospital services, they are REH services. So CMS first went in and said, we're going to expand some of these hospital-specific compensation arrangement exceptions for Stark to include rural emergency hospitals. For some reason, they didn't include the medical staff incidental benefit exception, so that will not be available to REHs as they go forward. Most importantly, we have this new Stark Law exception for REH ownership exception. So this is ownership in the whole hospital, ownership in the whole REH. CMS notes, as we all know, that the rural exception is nearly impossible, if not impossible, to navigate because it requires that the designated health service be furnished in a rural area, and at least 75% of the patients receiving that service in a rural area are in fact rural residents. And it's very, very challenging to track that data on a regular basis, especially when the definition of rurality changes with every census period. So it's very challenging, if not impossible, to utilize that rural exception. So instead, CMS is recognizing a whole hospital ownership exception for rural emergency hospitals, which tracks the good old, now outdated, all hospital exception for hospitals generally. Very restrictive in terms of you can't have an added benefit that encourages you to be an owner because you're a physician. I think that invites comment as well, because for some of these facilities, we want to encourage physician ownership because it is more likely to provide staying power. And the whole idea behind REH is staying power for these rural communities. So is there comment here potentially on relaxing this standard and instead using this really as an incentive to get more providers into these rural communities? Finally, last topic, number 10 on the list. So we're shifting gears from REH. Just to note, a very brief request for information from CMS included in the proposed rule regarding the use of CMS data to drive competition. In this section of the proposed rule, there is a discussion of Executive Order 14036 and the accompanying fact sheet that talks about the impact of consolidation on the healthcare industry generally. That fact sheet makes two very broad conclusions: that consolidation tends to raise prices in concentrated markets, and consolidation tends to eliminate services in rural communities. And those conclusions have been derived from analysis of Medicare claims data. Here, CMS is asking for commentary on whether there are more opportunities to use this data to analyze more deeply the impact of mergers, acquisitions, consolidations, and changes of ownership, CHOWs, on the affordability and availability of care. So we know it very clearly. The FTC, Federal Trade Commission, has told us repeatedly. The Department of Justice has told us repeatedly. They are very focused on consolidation, anti-competitive behavior in the healthcare industry. This is just yet another sign of the times here in the proposed rule. So that is our quick and dirty through the OPPS rule for this year. Please join us again on August 31, 2 weeks from today, where Kathy and I will dig our way through the fiscal year 2023 final rules. So this is the inpatient rule, SNF, rehab, psych, hospice. Kathy, have I got all of them? I think that's the whole set.
You got them. You got them.
You finally trained me. So we will see you back here on August 31. Thank you so much for joining us today. And Laura, back to you.
Thank you. And thanks to our presenters, Martie Ross and Kathy Reep. If you have any questions, their presentation and contact information will be emailed to you, along with a recording of today's webinar. Also, if PYA can provide assistance with audit, tax, compliance, valuation, or physician services, please call or email us. You may also visit our website at pyapc.com for more details about our specific areas of expertise, or to subscribe to receive PYA insights. Please remember to stay on the line once the webinar disconnects to complete a short survey. On behalf of PYA, thank you for joining us and have a great rest of your day.